Hi, I'm going to talk today about a therapy model I developed called Disability Affirmative Therapy. This is a template to help any clinician or psychotherapist learn about a client who has a disability in such a way that they understand how to put the disability into a context. Or for a client to say, these are the areas I want to talk with you, my therapist, about. And my name is Rhoda Olkin, and I'm the developer of Disability Affirmative Therapy. And I'm a distinguished professor and program director at the California School of Professional Psychology and executive director of the Institute on Disability and Health Psychology. I've also written a book about psychotherapy with people with disabilities and have a training tape available. This is how to contact me if you have any questions about this video. So I'm going to walk through 8 different areas that are the template of disability affirmative therapy. And the 8 areas are 8 considerations that the therapist might think about when thinking about any client who has a disability, including polio or post-polio. And the first area in there is developmental history. The second area is the client's model of disability. The third area is the interplay between disability and other client variables, such as ethnicity or gender or socioeconomic status, religion, or sexual orientation or age. The fourth area is disability culture and community. The fifth area is how disability affects social interactions. The sixth area is the cumulative effect of microaggressions. And if you're not familiar with that term, don't worry, I'll be defining it. And then seventh are the affective prescriptions and prohibitions. And then lastly, how disability affects areas of intimacy. So this first area is about a person's developmental history. Often we think of disability as being the essential primary feature of the person with a disability, but it isn't. There are things that go along with having an early onset disability that we have to understand. And one is, particularly for people with polio, whether you were raised to think of yourself as quote unquote normal. That is, that you could do anything anyone else could do. And then what was it like for you when you realized that you weren't normal, that in fact you had limitations? Were you trained to think of yourself as a person with a disability, or was the disability something separate that was outside you? In other words, was disability integrated into yourself? A second part of how you were raised with a disability is whether you were trained in advocacy. So for example, there are a lot of laws for people with disabilities. Were you trained to ask for reasonable accommodations? Were you trained to get bus drivers to put down the lift? Were you trained in being a good advocate? In addition, were you trained in doing medical decision making? So I'll give an example. Suppose you had a child with diabetes who had to give him or herself shots. Well, obviously when the child is 3, the parents or a teacher would give the shots. But when the child is 16, the child would be giving himself or herself shots. But where between 3 and 16 should that transition of self-care be moved from adults to the child? And so that's the kind of thing I'm talking about in terms of being trained in self-advocacy. Were you, as a child, a part of that transfer process with your parents? Third, did you have a history of medical trauma and separations? So did the onset of polio, for example, involve a long hospitalization? Did you then have surgery and go back into the hospital? Were those traumatic experiences for you? And then what was your romantic and relationship history growing up as a child with a disability, particularly in middle school and high school? What were the early lessons you learned about yourself as a romantic partner? The second area I want to talk about in disability affirmative therapy is about models of disability. What is the client's model or your model of disability? What is the therapist's model? And what was the family's model? And I'm going to be talking about 3 predominant models of disability: the moral model, the medical model, and the social model. So in the moral model, the meaning of disability is that disability is a defect caused by moral lapses or sins. It's denoting something underlying in the character that's wrong or flawed. And sometimes in this model, it includes the myth that as one sense is impaired, such as sight, another sense is heightened. And we see this, for example, in Greek literature with the blind seer, who doesn't have literal sight but has inside sight. The moral implication of the moral model is that it brings shame to the person with the disability and often to the family or maybe even the whole community. A sample idea in this model is God gives us only that which we can bear. And an example that comes from a Gaelic plaque that I saw in a mail order catalog. The plaque said, "May those who love us, and may those who don't love us, may God turn their hearts. And if he doesn't turn their hearts, may he turn their ankles so we will know them by their limping." And this is a common literary device where you give a protagonist a physical impediment to denote something about their character. This is by far the oldest of the three models, but worldwide, it's still by far the most prevalent model. So if disability is a sin or a lesion on the soul, then the goal of intervention here would be spiritual or increased faith, forbearance, finding meaning and a purpose in what might be called the affliction. But every model has its benefits and its negative effects. So the benefit of the moral model is maybe perhaps having been feeling like you're being selected, having a relationship with God, feeling a sense of greater purpose. And an example of the benefit is a cab driver I once met who was from the Middle East, who told me that when he was 10, he stepped on a landmine and blew up his leg. And then he went into the hospital and had something like 12 different surgeries. And then he moved to the United States. Now he was driving a cab. He was in his 50s. And he said to me, "Every day I wake up in pain. And it reminds me to thank Allah that I'm alive." And that to me is the benefit of the moral model, is finding some purpose in his disability. The negative effects are that often people with disabilities are kept hidden. They're ostracized from the family, from the community. There's a profound feeling of shame and of having to hide not only the disability, but the person with the disability. Now, the medical model, which came about in the mid-1800s, the meaning of disability is shifted, and now it's a medical problem that resides within the individual. It's a defect in or a failure of a bodily system and is inherently abnormal or pathological. The moral implication is it's no longer a lesion on the soul, but now it's a bodily or systemic problem within the person. And you may hear blame for the person having the disability. So for example, something simple like you go out without a sweater, you'll catch a cold, you're a type A personality, you're more likely to have a heart attack. So now we hear blame of the person for habits or behaviors that might lead to disabilities. Sample ideas in the medical model, patients are described clinically, such as the patient has left hemiplegia and some spasticity in the left arm, or there's an incomplete lesion at the C4 level. The origin is in the mid-1800s. This is by far the most common model in the United States, and it's the model that underlies most of the medical journals or the rehabilitation journals. The goal of intervention is cure, but since you can't cure the disability, what you're trying to do is ameliorate the physical condition to the greatest extent possible. So rehab is the adjustment of the person to the condition. And these patients or clients are expected to avail themselves of a variety of services offered by trained professionals. So you are the helpee in a variety of different venues. The benefit of the medical model is that there's a lessened sense of shame compared to the moral model. It promotes faith in medical interventions. There's a defined patient role, and it has spurred tremendous medical and technological advances that have in fact improved the lives of people with disabilities. The negative effects are that it's a very paternalistic system. There's an isolation of body parts. It's not you as a person with a disability, it's you with a leg that doesn't function as well. So there's a failure to integrate the disability into the whole, into the self. You have a part of your being that's abnormal. It's about doing to the person with a disability instead of with the person with a disability. And it promotes research by outsiders. I'm going to make a paradigm shift now to the social model. In the social model, disability is a social construct. That is, the problems lie in the environment that fails to accommodate people with disabilities. People with disabilities constitute a minority group that has been denied its civil rights, equal access, and protections. So now the key impediments are not failures of body parts, but the key impediments are things like prejudice and stigma and discrimination and social isolation, unequal treatment, economic dependence, high unemployment, inferior or inaccessible housing, and a higher rate of institutionalization. And the moral implication here is again not about the person, but about society, in that society has failed a segment of its citizens. Sample ideas: nothing about us without us, which was the slogan of the anti-apartheid movement in South Africa, and then the disability movement in the United States adopted that slogan. Or, you gave us your dimes, now give us our rights, which is from the March of Dimes. The origins of the social model were the early 1900s, and then it virtually disappeared until the mid-1975 protests, which happened in Washington, D.C. and in San Francisco, and the protests were about getting the Rehab Act signed and implemented. Now the goals of intervention in the social model are not changes in the person themselves, but the political, policy, economic, and social systems that directly affect the lives of people with disability, and making increased accessibility of places and of services. The benefit of the social model is that it really integrates the disability into the self. There's a focus on how the world disadvantages people with disabilities. There's a sense of belonging and even a sense of pride in the disability community. The negative effects are that you can feel quite powerless in the face of having to make these broad systemic political and economic changes. And it isn't that any one person or any one family falls neatly into one model as a general rule, but think of it as 3 cups, and each cup can be any amount full. So people might believe in the moral model to a great degree, the medical model to a little degree, and then the social model to not any degree, and so forth. Then we need to think about the interplay between disability and other variables. And there are some very particular variables to be thinking about that you would want your therapist to know about you. You are not just any person with a disability. You're a person with a gender, you have an ethnicity, you might have a religion, you've had a type of onset of the disability. For example, it might have been a traumatic onset, it might have been an early onset before you were born, it might have been congenital. Then we have your current age, your sexual orientation, and very importantly, your socioeconomic status, because disability often incurs a lot of expenses. So if you think about the type of onset, just think about what your reactions are when you look at these pictures. We see a baby who might have been a product of the mother taking thalidomide. We see what looks like a blind blues player. We see cigarettes, which are the cause of much disability. We see a warning, not everyone who gets hit by a drunk driver dies, and the implication here is ending up looking like this would be worse than death. We see a person who possibly has Down syndrome. We see a car accident. Our reactions to the onset and the type of disability because of the onset are quite different sociologically. Fourth, I want to talk about disability culture. There is a disability culture, but it's pretty hidden and very underground. If I said to you, go out and find disability culture, a lot of people wouldn't know where to look. So one question for your client is, does your client know that there's been a disability culture and community? Would they know how to find it? Would they know what magazines there are? Would they know where people congregate? If you're going to help your client be affiliated with other people with disabilities, who are, after all, the most important source of other information about disability, then you need to help your client hook up with his or her community, much like you would for, say, a new gay client who's starting to come out. You would want to help them find their gay community. You want to help your client with a disability find the disability community. What is disability culture? Well, there's an in-group and an out-group, and the in-group is people with disabilities and those affiliated closely with them. There's a sense of pride in membership and being a person with a disability. There's a shared personal history and a societal history. A philosophy of the group, which is the social model. There's a language, like for example, we talk about TABs, people who are temporarily able-bodied who might join the disabled community at any time. We talk about people using chairs, meaning wheelchairs, etc. And then there's disability norms. For example, if I'm walking on crutches, I might hold something in my teeth because I don't have hands available, and that would just be normative in my community. We have role models and leaders. We have commonalities of concern. We have membership in a protected class. And we've developed expertise in things like what is accessible, what are the rights of people with disabilities. We know a lot about specific disabilities. We use assistive technology, and we see it as an extension of the body. It's part of the self. There are certain attributes that are valued within this group, such as advocacy. We're often seen as a group by the media, though, called the disabled, as if we're one conglomerate, and perceived shared attributes, which is people with disabilities are supposed to be plucky or cheerful. The fifth area is the effect of the disability on how others interact with you. Are you seen as one of a member of a group of people with disabilities? For example, I had 2 students with visual impairments who often got called by each other's names. That's just seeing you as one of the women with disabilities. Does your therapist understand what is really unique about your disability for you? Were you trained and raised to interact with both people with disabilities and people without? Or were you segregated in some way? And are you allowed or required to follow the affective prescriptions and prohibitions? The 6th area is microaggressions, which are brief, commonplace verbal and nonverbal behaviors or elements in the environment that communicate a hostile message, are derogatory, negative slights, invalidation, insults, and they are about you having a disability. The result is that you might feel overlooked or under-respected or devalued. And that doesn't mean that that's what the person intended. It's often a very unconscious process. And I've included a reference here if you want to read more about microaggressions. The thing about disability is that a lot of the microaggressions might be in the built environment. There might be stairs with no ramp. There might be a clothing store where you can't get to the clothes themselves, a door that's too heavy, an airplane that doesn't let you go down the aisle in your wheelchair, a faucet that's hard to move. So there are areas of microaggressions that are common for people with disabilities, and I'm just going to give you the reference on this, and I'm not going to go through the 8 different domains of types of microaggressions. You can read about those for yourself. But the effect of microaggressions is not benign. They have a major effect on mental health, on physical health. They create a hostile environment. They perpetuate stereotype threat. They can often create real physical problems. And for most people with disabilities who are working, they decrease the productivity and create inequality. So we might see as a result depression, anxiety, anger, or feeling misunderstood. The 7th area is affective prescriptions and prohibitions. People with disabilities are expected to be either in mourning, because disability is seen as a loss, you must be mourning the loss, or if you're not, you go all the way the other way and you're seen as being plucky, always cheerful, always smiling. What you're not expected to be is angry, because that denotes that you haven't adjusted, whatever that is, to disability, and you have a chip on your shoulder. And lastly, we have the area of friendships, romantic partners, and sexuality. What kind of friendship patterns does the person have? Do the friends know about disability, talk about disability? Are they people with disabilities? What's the romantic partner history, and what's the effect of the disability on sexual expression and feelings? So in disability affirmative therapy, you need to think about what is your therapist's model of disability, what is the supervisor's model, what is the client's model. Is the client getting the benefits of the model, or is the client mostly experiencing the drawbacks of the model? I think that the therapist should adopt the social model, but should not insist that the client does. What you're trying to do is to help the client realize the benefits of the model and minimize the deficits of the model. But you as the therapist should not just be thinking about what's in the room, but also about political, legal, economic, financial, social, educational, familial, and the personal impact of disability. You should help your client become familiar with the disability culture. Treatment must be made accessible, which is going to mean different things for different clients. And the goal of these 8 different areas is to help you, the therapist, incorporate disability into the case formulation just the right amount. Remember that the stage model of response to disability has been discredited. Depression is not a normal response to disability and should be treated aggressively. Disability should not be viewed as inherently pathological. And these 8 elements which I've described are just ingredients. Your responsibility is to put them together to make the cake that's disability affirmative therapy. I've given you a reference here if you want to read more about this. Thank you very much.